It's my pleasure to introduce Dr. Phoebe Moore, who will introduce today's speaker. As you know, Dr. Moore is the Vice Chair for Psychology in the Department of Psychiatry, also a Director of the Career Development and Research Office, and a clinician in the Student Counseling Services. Dr. Moore.
Hello, everyone. I'm pleased and honored today to introduce Dr. Tim Sanis. Dr. Sanis is a clinical health psychologist. He received his PhD at the University of Florida in Gainesville in 2013. He completed his pre-doctoral internship at the Puget Sound VA and went on to a postdoctoral fellowship in palliative care and aging at the University of Colorado. He has been a faculty member at the University of Colorado School of Medicine, as well as at the Department of Psychiatry at Harvard Medical School. We were lucky enough to recruit Dr. Sanis to UMass Chan in 2023, and since then he has been embedded in the Cancer Center, working with patients who are coping with life-threatening illness and their caregivers, while continuing as a scientist practitioner his program of research. Dr. Sanis is a leader in the field of behavioral medicine. He developed and implemented the first behavioral medicine service at Dana-Farber Cancer Institute. While maintaining a busy clinical practice, he has received multiple internal and foundation grants to improve understanding and implementation of psychosocial interventions for medically ill patients. His research has focused on mechanisms underlying well-being in cancer patients, expansion of tailored support for patients and their caregivers, and the study of treatment, decision-making, and assessment approaches in cancer care. Dr. Sanis has 50 peer-reviewed publications and multiple book chapters, and has presented nationally on his ideas and his research findings. In addition to his academic accomplishments, Dr. Sanis is a highly skilled clinician and a clinical team member. His colleagues and collaborators in cancer care describe him as compassionate, skilled, and creative, and highlight that he is a big, innovative thinker with a vision to improve the care of people living with cancer and their caregivers. Please join me in welcoming Dr. Sanis, who will be presenting today innovative approaches to engaging cancer caregivers. Head in the clouds while working down in the weeds.
Thanks, Phoebe. Thanks so much, Phoebe, for that wonderful introduction, and thank you so much for having me present here at Grand Rounds. This is really exciting, and get to break from the busy clinic and talk to you guys about some research I've been involved with, some stuff I've been doing since I've been here at UMass. So thank you again for having me. So I don't have any disclosures. I will talk about some national organizations that I'm affiliated with. One of my close colleagues that has a book that I will not hawk during this time, so I don't have any financial disclosures. But just really, really excited to talk to you guys about some different ideas I have around caregivers, and I'll clarify what I mean by caregivers here in a second. But some of these ideas have been in the works for a while, and so they may seem a little bit different, which is why I titled it Head in the Clouds. But I also am in the clinic every day, and Dr. Moore, Dr. Yonkers are really helping navigate some of the weeds and the different, logistical things in a new system that are important. And so my hope is that maybe I'll present some new ideas, things you haven't thought about before while we're in the clouds, and then also maybe if I really achieve my goals, impact how you think about clinical practice, think about new things that are coming out in ways that we can address suffering overall. And so when we talk about caregivers, UMass has done a wonderful job using that word to include all of us, right? Because we all care for patients and we're all caregivers. And that's a broad kind of definition, I would argue. And it's important because we all, again, are in this together. I think it speaks to the teamwork. But before coming to UMass, I would argue that caregivers in my world have often been those in the family, right? So those right around the patient's daily lives, those giving them rides to appointments. And so family caregivers is what I will be talking about from this point forward, right? So it's not to dismiss all the incredible work that we do and framing caregivers in a broader sense, but today I'll be talking about those family caregivers, those that some of you may have already been caregivers, There's a reasonable chance you will become a caregiver at some point in your life. And so really narrowing our focus to those family members that help care for loved ones. So this slide does not do the scope of the problem justice. There are 53 million family caregivers in the US. And so you can argue that this is actually an invisible backbone of our healthcare system. I read it, the state of Massachusetts, it's somewhere around 780,000 active caregivers today caring for patients with serious illness outside of those that are paid, right? So this is unpaid work. And I don't have to, for the clinicians in the room, I don't have to tell you that if we were to give measures of well-being to patients and their family members, a lot of times family members are actually more stressed, right? And so you guys have probably felt that before. You've seen it in your clinical practice. And that translates into health costs for those family members overall and increased mental health care utilization in those family members, right? They're at risk for poor health outcomes and including poor mental health outcomes. And for better or worse, I might argue for worse, our medical system is actually moving even more into this kind of model of care at home. What can family members provide when we want to discharge folks who want to, you know, again, often patients want it, but there is a shift towards more home-based care. And in my world, oncology, that is particularly true. And I'll highlight some examples throughout this. As behavioral scientists, we've also made great strides. We've developed a lot of interventions to support family caregivers. And again, this is now narrowing our focus to cancer because that's my world. But there's at least 75 evidence-based interventions that exist out there. And for dementia caregivers, there's probably over 300 of these types of interventions. And so what I will kind of focus on for the rest of the talk is, that's great, but how do we actually get those caregivers in? And I think we need innovative ways to think about engagement with these incredibly important unseen members of our team. So now caregivers, I say they're stressed. I say we have the interventions. They also say they want more support. But again, there's a lot of barriers. There's barriers that I'll break down in a nuanced fashion in the second part of the talk. One estimate suggests that if we created a family support center here at UMass, that probably only a quarter of caregivers would actually take us up on the invitation to come in, right? That it's hard to engage these family members, these loved ones that are completely focused on the patient. Taking time for themselves is almost foreign. And just similar to patients, their emotional concerns don't necessarily mean that they'll participate in these interventions that we develop. And so I'll come back to this, but there's a wide call for more distress screening in caregivers, and that's something I've implemented and I'll talk about. But again, I think we need to think a little bigger about innovative ways to engage caregivers. And so if you'll bear with me, I'm going to kind of go off into the clouds for a little bit and talk about a line of research that motivated a project I've continued here at UMass, but we have to go all the way back to like my dissertation. So bear with me for a second, okay? So there are psychiatrists in the audience, biological researchers that know what cortisol is, right? Most people know it's a stress hormone. People know what that is. You may not know that it's actually a rhythm throughout the day, that it kind of goes down as the day progresses. So it's something like this. But the yellow dots, and again, I'm not going to dive too deep. If anybody wants to talk stats afterwards, I'm happy to stick around. But basically, capturing this rhythm in a meaningful way is tough, right? Because we have this daily rhythm and we want to try to capture it. And so one of the things I dove into early on in my career is like, is there any meaningful data we can glean when we give people measurements of cortisol? So cortisol we can collect in saliva, and that's what the data I'll present is on. You can also collect it in hair. I won't talk about that, but this daily rhythm is actually important. And so this is kind of what it looks like if we actually try to grab a hold of it. And so I won't belabor what cortisol variability is, but suffice to say, it's one unique way to kind of measure this cortisol rhythm. And so it's been shown to be disrupted in major depressive disorder, remitted bipolar disorder. And I could talk about all the nuances of cortisol measurement for the rest of the hour, but I'm really just giving it as background to how I think about stress and the importance of biomarkers, right? So it's an example. So for my dissertation, again, could go in any of these projects, basically showed that women undergoing surgery for suspected endometrial cancer those with higher stress had a greater disrupted cortisol variability. We actually went on to show, when I collaborated with some colleagues at Fred Hutch, that this variability estimate seemed to be more responsive to intervention when compared against other types of cortisol output. And so it actually, in a randomized clinical trial setting, seemed to be more sensitive to change after it said intervention than other measures of cortisol. So we were thought we were onto something. I spent a lot of time and energy looking at cortisol data and collaborating with several different groups, because at the time, a lot of people had this type of data. So again, happy to talk about cortisol offline. But this is how I found my way into caregiver research. After Dr. Moore mentioned that I did my postdoc at University of Colorado. And so when I went to University of Colorado, they also had access to this cortisol data. They had been collecting this in caregivers of patients that were undergoing bone marrow transplant. Extremely high stress time, and we replicated our findings. We actually showed in higher mental health composites, worse here on the right, actually showed that this disrupted variability of cortisol output was seen in this group of caregivers. And so the late Mark Laudenslager and I have published this in Psychosomatic Medicine and thought we were kind of onto something. But in reality, it was part of a larger body of research that showed caregivers are not only stressed when we ask them, but their physiology is disrupted, right? And this has been shown across dementia caregivers in addition to caregivers of cancer patients. And so this is again, contributed, I think, in a small way to a larger body of research. This is, there's a lot going on for caregivers. We know that, but we can actually see it at the biological level. And so there's a lot of work in this area, but we had this intervention, right? We actually, what I showed a second ago was actually cross-sectional data. And it was part of a larger study where we were able to reduce stress, right? We actually, our team showed that, in fact, after a cognitive behavioral stress management intervention, these caregivers did better. And that's on the right. We didn't show any impact on the patient, which is maybe a topic for another day. That kind of indirect effect of caring for the caregiver, we didn't see in the patient. But it's still incredibly important that we were able to reduce stress in this highly burdened group. But that's all the background that really fueled the project that I'll present. So I just want to take 1 second for those that have mentors in the audience, right? It's an important relationship, and Mark Laudenslager actually passed during COVID. So the best way I could honor him was to keep the work going, right? And so I just wanted to share that not only was he a special mentor and important impact in my life, but keeping up what you start as a team, I think is so important. So we did a lot of work with his data showing that anxiety was more related than depression over the course of bone marrow transplant in these patients and caregivers. Sleep actually was, at the beginning of the intervention, actually was a driver of how impactful the intervention was. And actually showed that the patient quality of life was more explained by the caregivers' ratings of distress than the patients themselves. So this overlap was incredibly important. And we knew that, but showing it, quantitatively was part of how we continued that important work that Mark started. And as a related plug, if any trainees are in the audience, I still have access to these data. I still have some things I'd like to do with it. For instance, we have a biofeedback device that we never really dove into. That's a pretty interesting component of it. But I think Mark was really a leader in the field, and I just wanted to highlight, again, how important that work was, but also that when you do that big trial, there's already so many questions embedded in that data. And so it was really meaningful to go back and look at it. So, but it brings me back, and it's the background that really set the stage for this idea of, okay, so what, right? What does stress markers actually mean? And that was always in the back of my mind. For anyone that's done this type of work, you probably had participants ask you, can I see my results? That was constant, right? So we would clip, I didn't talk about hair cortisol, but we would cut people's hair. We would measure their hair cortisol, and they would undoubtedly say, well, what's my level, doc? How stressed am I? So it set the stage for like, okay, fine. Can we use that information? Is it meaningful, right? To actually talk to people at that moment about how much stress they're under. But you also, for those in the audience, are probably thinking, gosh, how can you share that? How can you measure something that's not validated, right? What would that look like in terms of the scientific approach? And so we actually, I wanted to do some of this work, and it took a while to wrap our heads around how we would do it. But we wanted to do it with caregivers, again, that we know are stressed. And the best approach was mock data, to basically walk them through what we would think presentation of these type of data might look like. And so that's what we did. A few years back at Dana-Farber, we recruited several informal caregivers in neuro-oncology. So this is the vast majority of caring for patients with glioblastoma, so a terminal illness. And so the stress is high. And we recruited these patients within neuro-oncology, and we put them through an interview, mostly run by me, where we're asking them, how do you know you're stressed? So we kind of anchored the conversation around that, and then dove into kind of how would you react if these biomarkers were presented to you, if we talked to you more directly about numerical representations of your stress. And so we analyzed these via qualitative analysis and a framework approach. And so the prompts, again, that I've referenced would be that trying to imagine this person is you, and I'll show the pictures here in a second, but someone showed this to you and said they think this is a sign you might be stressed. How do you feel? Would this make you want to do something about your distress? How would this compare to the gold standard, which is questionnaires, right? We give people PHQ-9 and we say, we think you might benefit from some help. How would it compare to that? And so these are, whoops, that was supposed to be not covering that, but basically these are all publicly available at the time. So there's a Fitbit kind of activity level. There's a hair cortisol test in the bottom left. There's heart rate variability. And then there's telomere length. And sorry, that was covered up on the bottom right. So publicly available or commercially available, I should say, tests at the time of the study's launch. And we would just want to see people's reaction. And so this was 18 caregivers, and there's the basic demographics. Like I said, the majority were caring for patients with glioblastoma. And the themes that emerged when we dove into this, and again, this was work that was started at Dana-Farber, and I kind of wrapped up after coming here to UMass. First theme was that, yes, caregivers are willing to engage in supportive care. So that's good, right? That if we ask them in general, how willing would you be to engage in extra support, they're willing to do it. So they trust the medical team. These are just some illustrative quotes. I hope I'm making the point that the second quote makes on the screen, that we don't acknowledge caregivers to the degree we should. And this actually fast forwards to one of my take-home points, which is turning to the caregiver and just asking how they're doing is incredibly powerful. And that's what they told us during the study, is that they are rarely the focus and they wish they were. What are you doing to stay healthy, right? And we know they don't pay attention to their own health. So they're kind of echoing the whole rationale for the study. But then we got into some of the other themes that emerged from this qualitative work. So these biomarkers are cool. You're showing us this stuff. And we could see that being impactful, but alone, they're probably not enough. So is there going to be a follow-up test, right? How meaningful is a test if you just do it once? And that, of course, makes sense. Can you have an impact? If I were to reduce my stress levels, would it make a difference to this test? And then again, this is more around, can you change it? So quick fixes, more treatment, something I'd want to reverse it if possible. And so these are all important things that you could probably intuit when you think about emerging biomarkers. But from what I could tell, because so much of this is in the commercial space, I hadn't really seen a lot of deep dives into people's reactions, particularly participants that we know are stressed and could benefit from more help. So, when we really dove into the biomarker question, though, it seemed like the heart rate variability and telomeres were the most impactful. So overall, this could be a wake-up call. This could be a call to action. In terms of heart rate variability, your heart is such an important organ. The participant would be upset if there were long-term effects from stress. And then the telomeres, and again, it's a company called TeloYear that is still around. The telomeres, the way it's presented, you automatically deduct that you have a shortened lifespan, which is pretty scary, right? If you see that type of graph, and again, we're asking them to imagine this is actually their data, but it can be a little bit shocking. And so that actually led to the final theme, which is kind of a background hypothesis, was that as interesting as these biomarkers are, they can actually increase people's stress, right? That they actually, by showing this to them, I don't know how many people have a smartwatch that tells you your stress at the end of the day. I mean, it's always been a question in the back of my mind, is as cool as these things are, what do they actually do for us, right? Which is the thrust of this work. But, this is like how many times they say stressed in this quote, right? That if I wasn't stressed before, now I'm stressed. Why are you talking about stress? I don't want to talk about stress. So, there are some downsides maybe to that. So this is one small project, but one I want to build on is, as I kind of settle in to my role at UMass and think about deeper dives into the caregiver experience and whether or not this is starting to scratch a surface on a meaningful, but also kind of innovative new approach to measuring stress. So people heard of digital phenotyping or the quantified self movement. And some investigators are actually developing entire interventions around that, right? That you could actually have called a just-in-time intervention where, you get an alert, hey, things have seemed pretty stressed the past week. You want to talk to somebody, is now a good time to maybe get some help with nursing care. I kind of made that up, but that's what caregivers tell me, right? That if there is going to be an intervention for them, it need to be broad, but it also need to kind of be immediate. And so, still kind of, I'll talk more about some future plans towards the end, but I think we can use some of these insights from this deep dive into the qualitative work with caregivers to understand, okay, there's a couple biomarkers that are particularly impactful, and we need to do follow-up. We need to actually engage with them after that one time. So this is kind of for the future. But that's all of the kind of ideas around, biomarkers, interesting, emerging kind of basic science. But I'm really down here in the weeds, right? So I just came from clinic. I could tell you a story about a caregiver that I was interviewing 40 minutes ago, if you want, right? But I'm down here kind of in talking about billing codes, Dr. Moore and I have a committee around improving our efficiency with billing. I mean, these things are important, right, to our practice, but they kind of feel like we're in the weeds. And so I wanted to divide up the talk that way because it's important to think about, okay, well, what caregiver engagement, like what does it actually look like in the clinic? And so that's the second kind of part of my talk here. And I wanted to put up one of the leaders in the field, a close friend and colleague, Nick Dion Odom, has really kind of led the charge, quote unquote, in the weeds, basically defining that, just like I highlighted at the beginning, we don't have a lot of programming at U.S. cancer centers for caregivers. And so again, we collaborated surveying U.S. cancer centers and showing that truly only about a quarter have any caregiver anything, right? And that he's actually taking that a step further and has a whole kind of implementation center at UAB. And so that might be a future partner, right? In trying to get some of these ideas off the ground and engaging caregivers. So he's dove in and defined some of the quote unquote weeds of this gap. But then I've also collaborated in my smaller world of bone marrow transplant to define that when we assess for psychosocial well-being in preparation for transplant, we also don't do a very good job of assessing for caregiver well-being, right? Or preparedness. So in this study that we rolled out through a colleague at NIH, it was really about half assessed the needs, but 13% had follow-up assessments for caregivers. And so this next part of the talk, I'll be diving into what exactly we might improve or different ways to think about that. Again, more in the weeds. So we also published a paper looking at if indeed oncology is moving more into the home setting, what do we recommend? Because there's a whole school of thought around doing bone marrow transplants, autologous bone marrow transplants in people's home. So for those that know what is entailed in that, that's huge. That's like Duke is doing this and a few other centers are doing this. But what it expects is that caregivers can navigate that entire process from their home. And so we published some recommendations around how far we might have to go as a healthcare system to really prepare family members. So again, highlighting kind of the bigger problem, but this is also in parallel to a lot of, and I won't get political, I promise, but there's a lot of momentum during the Biden administration coming out of COVID to address some of these issues, knowing, people have heard of the silver tsunami, right? And that there's an aging population, often relying more on caregivers. And so the Biden administration really, some of the American Rescue Plan that came out of COVID transitioned into more concrete strategies to promote and support family caregivers. And that's actually really exciting. I hope the kind of last chunk of this talk is motivating you that there's momentum in the larger, even if it's political realm, to address some of these issues. So that's happening in parallel while we're on the ground talking about cancer caregivers and the need to support them. There's national, legislative momentum around that. So, simultaneously, we're still trying to roll out these interventions. I mentioned that the biomarker work that I did was with caregivers of neuro-oncology patients. I collaborated with some folks at MGH to design an intervention and roll that out for caregivers of patients with brain tumors. It was effective. That's great, but it's still how do we get them in the door? And so if we think about where we are in the weeds, where we are is documentation, right? That caregivers, and this is part of the American Rescue Plan, was we have to document caregivers. There's actually a requirement now that when a patient walks in the door, we should document who's caring for them, who's helping. That's where we're at, right? And so my colleague Alison Applebaum basically further kind of echoed that call in that oncology, it's critical, okay? And so we feel that alone offers an incredibly important opportunity to provide more care for caregivers, excuse me. So not only is it a requirement to document caregivers and who is the primary caregiver for patients, but Dr. Applebaum is actually arguing we should create their own chart so they can have their own healthcare, right? It's not that wild of an idea, but if you think about how we interact with patients, it's a little bit outside of the box. And so that's what I want to dive a little bit deeper into, what that would look like. And again, in the clinic, how we might actually do that. And so the background around this is that in 2012, some of the leaders in caregiving research at the time said, gosh, we need some code, right? We need some way to document these caregivers' burden, the level of stress, the amount of time they're taking off. We've got to document this on some level. And so they were talking at the time about ICD codes. And so that was fairly early on. And this is, again, part of the background that Dr. Applebaum and I kind of dove into to outline exactly what we found or thought at the time were the challenges to honoring caregivers' burden, but also potentially engaging them in more care. So I'll go through those challenges now, and then hopefully, again, we'll have sure we'll have time for questions towards the end. So the first challenge that we highlighted is that caregiver burden is not a formal medical diagnosis. Okay, psychiatrists in the audience, I don't need to put the DSM up there, I will. But you know what classifies a mental disorder, right? And so maybe this is a provocative slide. We can talk about what if burden makes sense as its own diagnostic category. But the point is that caregiver distress rarely falls into a neat diagnostic category. Burden is one of the better terms I think that's used out there. Sometimes caregivers, honestly, they don't think it encompasses what they go through. And so just like in some other maybe cloudy disorder diagnostic categories, we fall in adjustment disorder at times. And so, you know, I don't mean to promote Dr. Applebaum's work too much, but she actually at Memorial Sloan Kettering founded a caregiver clinic, and that was the most common diagnostic category used, right? Was adjustment disorder. So there's a little bit of data that when we try to capture caregivers' experience, we fall back on that. And caregiver burden as its own diagnostic category might allow for those folks to actually get care appropriately. I mentioned this briefly, but it's worth really highlighting, which is, you know, if we don't create caregivers' own medical chart, then we're really hamstrung by how much care we can provide for them. You know, once we do, we're still tied back to challenge one, which is, okay, we created their own chart, we have you know, available providers, and we are going back to traditional psychotherapy codes. And so this is, if you're interested in this, I'm happy to send you more around this. There are some Z codes that have come out that are more around, you know, that the physicians can use around family training. And so we highlight some of that in our article. But it's an ongoing challenge, right? How do we actually document outside of a patient's encounter what caregivers experience? And then the third challenge, which is, again, probably very well known to this audience, which is mental health care is hard and integration is tough. So we can't ignore that talking about better support for family caregivers comes in the context of challenges in mental health care delivery in general. You know, this is one estimate of the dramatic increase in kind of mental illness in this country. We know there's low reimbursement rates, and that stigma is a barrier. We all know that. And at the same time, caregivers, when you ask them, they almost always want to handle this stuff on their own, right? That across the board, they really, as I've kind of mentioned, don't always feel like extra help outside of themselves is needed. So it occurs in that bigger context. So from this, you know, the takeaways are that caregivers provide a ton of unpaid assistance in delivery of healthcare at large, and that mental health challenges come as a result of that, but also at a huge cost to the system, to the caregivers, to the families, and that we need to do a better job of supporting them. I've argued that caregiver burden as a diagnostic category could increase access to mental health care and more accurate documentation and billing for caregiver burden, right? To uniquely honor what they go through. And then again, this audience is well aware that so much of our current healthcare system is tied to patient, you know, focused care, and that makes sense, but it creates a circuitous way to billing for the broader context of the family and these caregivers. And so for anyone that's interested in this, we published this in the Journal of Clinical Oncology, Clinical Psychology and Medical Settings in September. And as exciting as that was, again, I think it's an important step to just highlight these barriers. There's actually been some pretty exciting things since. So the last kind of chunk that I want to talk about is where things stand today. And then I'd love, again, I think we'll have more than enough time for some thought and discussion around these issues. So that was, again, at the end of just a few months ago that we kind of put that article forth. The National Alliance for Caregiving, if anyone's interested, they're probably one of the biggest advocacy groups around these issues. They released a document this summer around incentivizing medical providers. And if you're interested in that, in any of these topics, they will have a whole appendix with those Z codes and kind of creative ways to maybe capture working with families. But there's again, even some more developments recently. I'm on the board of directors of the American Psychosocial Oncology Society. We did a webinar on this topic about 3 weeks ago now, and got some really good feedback. We actually partner with the National Alliance for Caregiving to do that. I have a nursing student I mentor right now who's diving into improving our documentation in bone marrow transplant of the caregiving plan, which again, that's like a very much in the weeds type of question that I'm kind of embarrassed to admit that we still could improve. And as I am passionate about these topics, it's hard to pull them off sometimes. So she's really diving into how we can, increase our efficiency with EPIC around caregiving. And there's also a toolkit that the American Cancer Society has released, talking more at a kind of higher level on from institutions, how can we increase support for caregivers, right? And how much admin support does one need? What, again, some of these in the weeds questions about billing codes are all in there. So that part of this is the momentum that again motivated these topics, but also I think there's a lot of positive directions that things are headed. And I think that that's a good segue into what has just been released. And I'm not a legislation expert by any means. So when these things actually are accepted, I maybe can lean on some of you guys. But right now, there is a unpublished, the new fee schedule for Medicare and Medicaid has the preliminary document that will be accepted at the end of this year, from my understanding, has been published and is online for public comment. And it actually includes some of this stuff. It actually includes ways to bill for caregiving training that a psychologist, a behavioral health provider, physicians can actually bill for. And so these are all new. And so one of my first questions when we held this webinar a couple of weeks ago was to the National Alliance for Caregiving, that follows this stuff a lot closer probably than anyone, was what does it mean? Do we think they'll actually be accepted? Do we have any idea what our views are? Right, getting right into the weeds right away. We have no idea, right? We don't know what kind of black box of insurance that we all have to go through. We'll kick back, but there are several of these codes that are included specific to caregiver training supporting family members. So it's not direct mental health care, but it is a broader, I think, scope and maybe lens to how we can acknowledge that we're not just meeting the patient and they're in isolation. They have a whole family network around them. So that's really exciting, and I'm happy to send you any information around this if you're interested. So I flew through some of that, but I want to just kind of recap because this is such a topic that is near and dear to my heart. I kind of started talking about things kind of in the clouds about my ideas about biomarkers. The metaphor might get a little bit much, but we're heading to Thanksgiving, so I didn't want to go with pie in the sky. But it is kind of that. I think if I had my way, a few years we will have a family support center at the cancer center, right, where we can actually welcome family members in for their own kind of restorative, visit. It would be amazing. We all know, and I've tried to highlight that there are barriers to that. And when we get into the weeds, so to speak, it becomes challenging. I do have a plan to use some of the qualitative data that I presented to submit for a small pilot grant, like an RO3 mechanism, to provide some caregivers actual, Fitbit or stress marker wearables to get more of that feedback in the real life, right? And to develop an intervention down the road that might actually be helpful in the moment in their daily lives. And so that's a kind of budding future direction. And as far as in the weeds, I think I have a lot of ideas about how we can better incorporate caregivers into our medical provisions and training. And PCORI is really interested in this. So those that know, the Patient-Centered Outcomes Research Institute is very interested in not just caregivers and improving well-being, but also, right, the application of emerging kind of billing codes and things like that. So I think there's an opportunity there, and I've not had a chance to partner with iSpark in the couple of years that I've been here, but I think that would be a perfect kind of overlap and fit for how caregivers, again, their suffering can be addressed. I put some of the new codes up here that are listed in that in case anyone's like really wants to try this tomorrow and see how the billing office responds. I think it remains to be seen, right? But it also speaks to the momentum, and I think some of the excitement that honoring, like I've said, the larger system could really address. So I hope that's true. I hope these new codes are used. I hope somebody in this room thinks about it down the road, or if it just gets you to turn your attention, like I said, to the family member, to ask how they're doing, right? And I feel like I've made a difference. And so that's, I think, important to think about. But before I wrap up here, and there's certainly time for questions, so I'm excited to hear y'all's thoughts. Just want to acknowledge that a lot of this work was not my funding. So it was a whole team of people over the years. Some of the early biomarker work was my graduate mentor, Dr. Pereira, Dr. McGregor at Fred Hutchinson, or formerly at Fred Hutchinson, the late Mark Laudenslager I mentioned. And I actually just want to kind of end on that I want to honor his memory, want to honor all of the different funding agencies, the work that I was able to start, and some of this came from my work at Dana-Farber, but also Alison Applebaum, Nick Dion Odom, you guys for listening and attending today. And of course, Bill Pearl is on the bottom right, who I believe Dr. Rothschild has worked, maybe trained here, or you guys have worked together at some point. So he's been a wonderful mentor and colleague through all this work. So with that, I'd love to take some questions and hear y'all's feedback. Thanks so much.
Thanks, Tim. That was terrific. And it's such an important area. We're really glad you're working on it. You may know that I'm the chair of the DSM steering committee. And so we entertain requests for changes, including new diagnoses or codes. Codes do not come from DSM. They come from ICD. So they're generated from WHO. All we do in psychiatric world is take the ICD codes that they tell us they're planning to publish and give them numbers so that it's easier for psychiatrists and psychologists, behavioral health care specialists to access it. It sounds to me like what you're suggesting is not simply a code, but something to go into the Appendix 3 as a diagnosis under which requires further study. And I would just caution you, that means you have to have a psychiatric diagnosis. So anybody that's going to get one of those codes will be assigned a psychiatric diagnosis. And it has to be unique in terms of the expression of the condition, a whole host of components. I would say that there's nothing to stop you from giving somebody a code like adjustment disorder, which is pretty benign, and insurance companies typically don't hold it against you.
Right.
And I think that's a safer way to go. You're going to have a problem with somebody, a family member acquiescing to a psychiatric diagnosis, period, whether it's, a new one that you hope to generate, or to be in DSM, or to something like an adjustment disorder code. But I think you're right that we need to find ways to access, to provide greater access to people. My question in following these comments is, Are there's some models for perinatal individuals where you can have sort of group, you can have support groups online and they include peers. And I don't know if they have, what's in this domain that people can access in tech world or online.
No, that's a great question. So in terms of the first one, yes, I don't think we went in the weeds too far in terms of the next steps to actually get it right in the different psychiatric, groups to actually vet this type of a suggestion for a code. And you're right, as an appendix, if it's still the psychiatric code, that's the kind of what we're trying to avoid. But no, I don't think we're there. It's more advocating for acknowledgement of this. I'm sorry, your second question was more tech intervention. So BMT InfoNet is the one I always point patients to, right? I'm not only in oncology, I'm bone marrow transplant is mostly where I live. They have wonderful online groups. There's like Leukemia Lymphoma Society has some of those types of groups. And so one potential idea is, right, you found an innovative way to engage them and then actually connect caregivers groups like that. And that's kind of where we're at, right? I'm continually looking at outside groups and seeing what's available. But yeah, there's certainly video groups for caregivers. In my experience, the kind of, those that are nationwide, right? They don't have the experience, they don't have the shared experience of that cancer center. They don't have it can feel a little bit disjointed for caregivers. But no, I think the more they can access things at home, right, the better. So I agree. I think we need really interesting or innovative ways to, I don't mean to be cynical about it. I just think there's general support is my sense. So I've not seen these out of the research realm. I've not seen a whole lot of structured, right, 6 to 8 session, more cognitive behavioral based stuff like the intervention that I presented. I've not seen a lot of that.
Thank you so much for bringing attention to this very important topic. I have a question kind of in a similar realm. So it sounds like it makes a difference to even ask caregivers whether or not, they're experiencing a caregiver burden or burnout. Once you do identify them as experiencing that, what are the next practical steps, especially here in Massachusetts in your clinical practice, perhaps? Where do you ask family members to turn to?
Yeah, I think, Kim's question around maybe online resources, right? If I have like a go-to, this is a great group, I would point folks maybe that direction. There are practical things, right? So there's like education around what their role is going to look like. So that's where I often spend a lot of time. So for instance, bone marrow transplant, one of the biggest drivers of anxiety is people just don't know what they're getting into, right? So there's education. And so maybe that's probably a big piece of it. But then there's also, some of the resources I put up here, I actually, have a printout that can give those to folks so they can understand they're not alone, right? And that there are other caregivers that have probably navigated this. I was interviewing a caregiver at 11, and they actually use LLS and the program they have to connect new caregivers, those that have been through it before. And that was incredibly impactful for them. And so I knew that program was there, but it was one of the first times, at least in the last, I think since they launched it, someone has directly reminded me that that's really helpful. Right? And I can tell them about what I've heard from caregivers. I can tell them about kind of my experience with bone marrow transplant, but it's just not going to be as powerful, right, as that connection. And so I think, I didn't highlight some of that work, but I have some colleagues that are testing similar types of interventions, patient kind of partner interventions in bone marrow transplant. So I think there's a lot of potential there too. So if it wasn't for HIPAA, I'd probably do that in my own clinic, right? I just connect folks all the time, but that can be one approach.
Hi, thank you, Dr. Sanis, for a great talk. My name's Jennifer Reedy. I'm Chief of the Division of Palliative Care. And we have the Palliative Care Fan Club right here for Dr. Sanis, who we love, and we love working with him in the Cancer Center. We wish we had more of him. We wish we could clone you. We wish we had more. Really phenomenal colleague. And so we in palliative care totally hear what you're saying in that every day we are taking care of our patients, but they're caregivers as well. right? Those are, that you can't separate those issues. And so we are here to partner with you going forward in every way. So thank you for doing that. And I had a couple comments and a question. One is, in case folks weren't aware, there is on the medical center side a group called the Patient Family Care Coalition. It's led by Alicia Waringa, who's the Chief Patient Experience Officer. I might get her title wrong. Forgive me, Alicia. But it's a multi-group stakeholder group that talks about all of these kinds of issues around caregivers, family caregivers, care partners, and how we treat them, how we work with them in the hospital and do handoffs and work with them at home. So there's a lot of allies and people to think about in addition to, you know, to complement the research. What are we doing now? What can we do now to help intervene and work together to advocate for these folks who are unpaid healthcare workers in the community and unrecognized? That's one thing. And then the second comment and question for you, Tim, is I'm curious about whether there's been any research on the role of community health workers to help family caregivers and sense of caregiver burden and mental health, because we know that, for example, the doula model in maternal child health and in labor, that is a highly successful model and something that we're even doing here at UMass that's very successful. And that's a person that can accompany someone through, you know, the medical system and the challenges they face. And I'm curious about community health workers to help with caregiver burden in where people live at home, and whether that might be an intervention that's been looked at related to caregiver burnout. Thank you.
No, it's a really good question, and thank you for the incredible compliments, Dr. Reedy. So I actually have not seen it as much in the caregiving space, but I think what you're highlighting is community health workers, right? I mean, that's by their name, have more connections, community inroads to those outside of the medical system, right? And so Dr. David Beckelman and I have collaborated on a intervention where we use community health workers as kind of almost health brokers between the oncology team and those underserved and Spanish-speaking patients, right? Because not just literal translation, but there's a medical translation. And that's been, Stacy Fisher has actually rolled that type of model out in rural Colorado and had great success increasing advanced care planning and doing that type of thing. And my understanding is that Dr. Beckelman is in the process of trying to translate some of those community health workers and lay navigators to address the caregiver space, right? But it's early on, and I think my sense is, just like I try to highlight in my talk, is patients first, and then hopefully we can kind of expand it out, right? But no, that's the one thing that comes to mind. And so, you know, I would argue, just like some of our under-resourced or patients that we probably aren't accessing as much as we should, caregivers are kind of the same way. And community, I love your idea. So let's talk more about it.
I have a question from Lori Pearson online. Thank you, Dr. Sands, for an excellent talk, excellent care of our patients. Anecdotal experience tells me that caregiver burnout may be more prevalent in older adults, hourly wage workers, and people of lower socioeconomic status. Is this supported in the literature? And if so, would these be groups to target with intervention?
Thanks, Lori. Thanks for attending and for your question. Yes. The easy answer is yes. More older adults, obviously, often can't have the kind of like the different physical responsibilities of caregiving, right? If you're moving your partner, it's, you know, 150 pounds. Gosh, that for anyone, that's tough. Older adults, higher risk of falls. So yes, the data is pretty clear that older adults often experience greater burden, more tasks associated with caregiving, increased burden, and the under-resourced patients have greater burden. So it's, unfortunately, I think the answer is yes across all those categories. And so, you know, there's also a question around, I don't think this is what Dr. Pearson was getting at, but I was talking about caregivers, right, in a broader sense with the family, but when we try to do research in different cultures, having one caregiver is actually not always very clear, right? And so we as researchers and say, hey, who's your primary caregiver? Who's helping the most? And some families have 8, right? And so that's, as researchers, that's our challenge. But I think it speaks to the idea of gosh, under-resourced, or different cultural backgrounds, all kinds of things that impact how much the caregiver is available, and if it's actually just one person, or are we missing the mark by trying to engage that one person, and should we be thinking more broadly? So thanks for your question, Lori.
I'm going to ask a cortisol question.
Please.
Because
I was
I
waiting.
spent the early part of my career doing that kind of work in severe depression. And we actually, saliva wasn't really available back then. So we used to get around the circadian rhythm by doing 24-hour urinary cortisols. But one of the things we always were wondering about is, people think of cortisol as like you presented as a marker of stress, but it's also not good for the body to have your cortisol be elevated, and it's really not good to be chronically elevated. And of course, there's a disease called Cushing's disease where that happens. But even at lower levels, there's all kinds of metabolic bad things that happen. But refresh my memory, the hair, that's chronic stress, right?
Correct.
It's like it measures over, I can't remember what the time period.
3 months.
3 months.
Yeah. So and I didn't I didn't talk about it, but that was part of the motivation for gosh, do we finally have something that's one number that signals chronic stress? And Dr. Laudenslager at the time was running a whole cortisol kind of core lab. And so it felt like, man, maybe we're getting there, right? We're getting to this where we have an abnormal range and we can do something with it. At the time, hair cortisol was also commercially available. And so that's part of the motivation. So it's talked about like hemoglobin A1C, where it's a snapshot. Do I really think that we have disrupted, maybe outside of something like Cushing's, and can we actually be sensitive enough? Probably not. But people are marketing it. So does that answer your question?
Yeah, no, I was just thinking more from a research standpoint. The nice thing about the hair sample, first of all, it's a lot easier than peeing in a bottle for 24 hours, but also it gives you a measure over time as opposed to just the last 24 hours.
Correct.
Which is, I think, more important. I mean, I think chronic stress on the caregivers is really what the issue is. It's not just a day or a week, it's months.
And actually even more, nuanced. Some investigators, so it's always at the root.
Right.
And you can divide it up into the first 3 centimeters. Some investigators have actually gone centimeter by centimeter to say that was a stressful month. The next month, not so stressful. Seems like it's normalized there. So that is like mass spec. There's a way to do it that's like most labs don't do. That's, I think, more sensitive. And the
telomere thing is also very interesting. We had a grand round speaker from UCSF. Can't remember her name, but about stress and depression and what that does to the telomeres and how it may not be such a good thing for a person's health.
Elizabeth Blackburn discovered telomeres at UCSF and showed that and Alyssa Epple was the one that kind of.
Alyssa Epple was who we had, right?
Oh, wonderful, yes.
Yeah.
So she connected that, discovery of telomeres with chronic stress. Some of that early work was actually with mothers of physically disabled children.
All right, well, it's 1 o'clock. Thank you so much.
Thank you, guys.